Candida species and other yeasts can spread through nosocomial transmission. They can be transferred to patients via the hands of healthcare workers or contaminated material, for example, intravenous saline for central venous catheter flushing shared among patients, which can cause outbreaks. Parasailosis is most commonly associated with nosocomial transmission, targeting neonates, patients with immunosuppression, and patients with indwelling catheters. Practical measures to prevent infection with Candida species include cautious use of antibacterial and mitigation of some of the preventable risk factors. Thus, strict adherence to routine infection prevention procedures, including hand hygiene and central venous catheter management, is crucially important. In this regard, the adoption of catheter care bundles as an approach to central venous catheter management has been important in reducing catheter-associated bloodstream infections. Most published data suggest that antifungal prophylaxis with fluconazole reduces the incidence of invasive candidiasis in patients in the intensive care unit who are at high risk of developing the infection but without a reduction in mortality. Stronger data support the use of targeted antifungal prophylaxis in selected high-risk recipients of liver, pancreas, small bowel, or hematopoietic stem cell transplant. Much less clear is the value of preemptive therapy and empiric antifungal therapy among patients at high risk of invasive candidiasis with unexplained symptoms but without clear mycological evidence of disease. Additionally, antifungal prophylaxis could theoretically favor the emergence of acquired resistance. The first Candida species vaccine candidate in humans targeting agglutinin-like protein 3 was recently tested safely in a phase 1 clinical trial and was efficacious in reducing episodes of vaginitis in women with recurrent vulvovaginal candidiasis in phase 2 clinical trial. Mechanistically, vaccine protection during invasive candidiasis is mediated by enhanced neutrophil recruitment in infected tissue. Vaccination will likely not be aimed at the general, healthy population but at specific patients at immediate risks, such as candidates for surgery or stem cell or solid organ transplant. In addition to early diagnosis, 2 clinical interventions are essential to the successful management of invasive candidiasis: source control and early initiation of treatment with early effective systemic antifungal therapy, usually before the diagnosis of invasive candidiasis have been confirmed. Owing to the paucity of rapid diagnostic assays for invasive candidiasis, most clinicians rely on routine fungal cultures and empirical evidence to establish a diagnosis. This approach can lead to the unnecessary use of antifungals in individuals without invasive candidiasis and also leads to delays in intervention with effective antifungal therapy for those who are infected. These delays in diagnosis and intervention could lead to much worse clinical outcomes. Source control refers to the elimination of the suspected nidus or focus of infection, such as the removal of contaminated intravascular catheters and effective drainage of collections of infected material, for example, peritoneal fluid, pleural fluid, or abscess material. Removal of these presumably infected prosthetic devices, such as cardiac pacemaker leads, prosthetic joints, or other devices, when feasible, is important to a successful outcome. Reducing infection associated with central venous access devices. The selection of an antifungal drug for initial treatment should be based on the patient's prior exposure or intolerance to an antifungal agent, the severity of illness, relevant comorbidities, and involvement of the brain, cardiac valves, and/or visceral organs. Additionally, the knowledge of the main Candida species and susceptibility data in a particular clinical unit should also be considered. Echinocandins are considered the first-line therapy for adults. They are appropriate for most patients with Candida parasailosis infection. Echinocandins inhibit beta-D-glucan synthase, an enzyme required for the formation of the cell wall, and have excellent fungicidal activity against most Candida species. They are safe and have very limited drug-drug interactions. However, they require intravenous administration. The azoles are a group of antifungal compounds with broad activity against most Candida species. Fluconazole is a second-line agent for initial therapy in most circumstances such as endophthalmitis, meningitis, and urinary tract candidiasis, in which echinocandins do not reach sufficient concentrations. fluconazole remains the standard initial treatment for patients with invasive candidiasis in parts of the world with limited resources and low prevalence of azole resistance. Hemodynamically stable patients who have had no previous exposure to azoles and who do not belong to a group at high risk of Candida glabrata infection, such as elderly patients or patients with diabetes mellitus or cancer, in settings where access to echinocandins is limited and parenteral therapy is impractical, are reasonable candidates for oral fluconazole first-line therapy. Azole antifungals inhibit lanosterol 1,4-alpha-demethylase, a key enzyme in the formation of ergosterol, which is a major component of the fungal cell membrane. They are generally well tolerated, have predictable drug-drug interactions, and can be administered as systemic agents either intravenously or orally. Voriconazole is an effective alternative for invasive candidiasis. This figure shows the algorithm for the management of invasive candidiasis. As yet unknown species, step-down therapy to fluconazole is usually based on documented susceptible minimum inhibitory concentrations to fluconazole and clinical stabilization of the patient. The information presented here is based on European Society of Clinical Microbiology and Infectious Diseases guidelines. After the patient's conditions are stabilized, step-down therapy is commonly prescribed and supported by clinical data. This transition is generally made within 3 to 7 days from initial therapy, but the timing varies substantially based on both the patient's response and the clinician's preference. An oral azole, usually fluconazole, is the first-line agent for step-down therapy. Candida species who received an echinocandin for at least 5 days and, once their conditions had stabilized and blood cultures were negative, switched to step-down therapy with an oral azole, fluconazole or voriconazole, or continued the echinocandin regimen at the same dosage of echinocandin. Voriconazole is an acceptable step-down agent for patients who are ready to transition from initial therapy to step-down oral therapy and who have fluconazole-resistant isolates. The duration of antifungal treatment is generally determined by the individual clinical and mycological response to therapy. Among patients with candidemia, follow-up blood cultures at least every other day until documented clearance of Candida species from the bloodstream are essential to establish the appropriate duration of treatment. In the absence of organ involvement, the duration of systemic antifungal therapy should be 14 days after clearance of Candida species from the bloodstream and resolution of all signs of infection, such as fever and hypotension. For patients with less common manifestations of deep-seated invasive candidiasis, treatment decisions are based more on experience and anecdotes rather than prospective data. For osteoarticular involvement, with chronic hepatosplenic candidiasis and intraabdominal candidiasis, there are no prospective treatment data, and most clinicians take a modified approach to therapy, such as initial therapy with echinocandins until there is a favorable clinical and/or radiographic response, and then transition to an oral azole, such as fluconazole, for several months. The duration of treatment in these situations depends on the site of involvement and ranges from several weeks to 6 to 12 months. Occasionally, patients require chronic, long-term antifungal suppressive therapy for refractory infections such as prosthetic valve endocarditis, chronic prosthetic joint infection, or infected intravascular devices that cannot be removed or replaced. Antifungal resistance is an emerging problem worldwide, and this further complicates the selection of appropriate antifungal therapy. Candida species strains that are resistant to first-line antifungals, such as echinocandins and fluconazole, are increasingly being recognized, and their appearance usually correlates with high azole and/or echinocandin background usage in hospitals or specific hospital units. The term multidrug-resistant Candida species is used to designate Candida species, strains that are resistant to 2 antifungal drug classes, whereas the term extensively drug-resistant Candida species can be used to designate Candida species strains that are resistant to more than or equal to 3 antifungal drug classes. Echinocandin-resistant isolates, especially Candida glabrata isolates, are frequently also fluconazole-resistant, and resistance to both classes of antifungals seems to be associated with worse clinical outcomes. The recent emergence of multiple drug-resistant strains of Candida auris poses especially challenging questions relating to effective therapy. Most clinicians favor a lipid formulation of amphotericin B for the treatment of patients with invasive candidiasis due to proven or suspected multiple drug-resistance Candida species strains. Amphotericin B is an antifungal drug with broad activity against all Candida species, but not against Candida lusitaniae, which is frequently resistant. An amphotericin B formulation should be taken into account in patients with a history of intolerance to echinocandins or azoles when the infection is refractory to other therapy, and isolates with suspected or proven resistance to other agents, and some deep-seated infections such as valvular endocarditis and meningoencephalitis, and for direct intraocular administration for endophthalmitis. It binds to ergosterol on the fungal membrane, which leads to the formation of pores, ion leakage, and ultimately fungal cell death. Amphotericin B has been associated with severe adverse effects, particularly nephrotoxicity. So, lipid formulations are preferred owing to their efficacy, lower incidence of infusion-related adverse effects, and reduced risk of nephrotoxicity. There have been no quality-of-life studies among survivors of invasive candidiasis. The most objective quality-of-life measure associated with invasive candidiasis is survival at 30 days. Most individuals resume prior activities without effect on the quality of life, and the risk of recurrent disease is quite uncommon, less than 10%. The majority of survivors of uncomplicated candidemia have no residual effects from the infection, except for patients with ocular involvement associated with candidemia, which is a major morbidity that can lead to permanent visual impairment, including blindness, if not recognized early and treated aggressively. Quality of life can also be substantially affected by the morbidity associated with a chronic persistent infection, including the need for additional surgical procedures such as cardiac valve excision and replacement, removal, and replacement of a prosthetic orthopedic joint, intraocular debridement, or intraabdominal surgical drainage or debridement. Long-term therapy is expensive and inconvenient and usually requires at least once daily administration. Additionally, it is also associated with potential drug-related intolerance, drug-drug interactions, and substantial direct drug-associated toxicity. Most of these drug effects, for example, elevated liver function tests associated with the use of fluconazole or voriconazole, are reversible upon discontinuation of the compound. Others, such as amphotericin B-related renal impairment resulting from long-term treatment, could be irreversible. Invasive candidiasis is the most common fungal disease among hospitalized patients and has continued to be a major cause of mortality. Although diagnostic tools and management strategies have improved, the changing epidemiology towards non-albicans Candida species and the emerging resistance to antifungal drugs are of increasing concern. The prevalence of non-albicans Candida species has been steadily increasing in many parts of the world. The selective pressure of antifungal use has further driven the emergence of species that are typically less drug-sensitive than Candida albicans, such as Candida glabrata, in settings with heavy fluconazole use, and Candida parapsilosis, in settings with heavy use of echinocandins. At this time, there is a crucial need for novel antifungal agents with new mechanisms of action to ensure the successful treatment of Candida species that are resistant to azoles and echinocandins. Thank you for choosing CRK, your clinical research key.